Hello, this lecture is dedicated to discuss about communication skills, just to discuss about communication skills. And you need to go to a workshop to practice communication skills, but we'll discuss about communication skills here. Our discussion will be guided by the Calgary-Cambridge model. I'll be discussing about skills that is required to initiate a session, to gather information, to engage in valuable explanation and planning and closing the session, but not forgetting the value of providing structure and building relationship. All those stages need skills of communication. We'll discuss about them. Before embarking in a journey of learning communication skills, it's better for us to understand what are the roadblocks to communication. Now, many of us do not have enough respect towards patient. When I say respect, it's not just the superficial social respect, but also intellectual respect, emotional respect, spiritual respect. And they have their own personalities, their own beliefs and ways of manners of behaving. So we need to respect them. And we need to develop rapport. Rapport is going beyond friendliness, trustworthy friendliness. We have to have eye contact. We need to greet our patients and avoid using medical jargon. We inadvertently use medical jargon, not realizing that we are misleading them. And we start criticizing in a very subtle ways. We start criticizing. You need to think and reflect about yourself. We start criticizing right from the beginning of a conversation. And then we just go on talking from one topic to the next topic without indicating that we are changing topics. No pause, no indication whatsoever that we are changing the topic. And that is one of the major roadblock to the quality of our communication. And then we do not develop an agreement with the patient on how to proceed on the consultation, what topics to discuss, how long to discuss, no agreement. And then we use judging words. We inadvertently tell them that you are ignorant, you do not understand things, and you are careless, things like that. And then we try to pretend to be busy, and we check our wristwatch, we check our time, and our language becomes sort of hurrying up, so that is not good. And then we use a lot of close-ended questions where you force the patient to say yes or no, or else to tell one or two words to express their ideas, feelings and emotions. And then we don't use a proper opening question. Now that is a skill that we should develop, where we ask an invitation, give an invitation to tell a story, and then we do not listen. I think it's first thing is that we should learn these important skills so that we will eliminate these roadblocks and become good communicators. We'll look at them again one by one. In the Calgary-Cambridge model of communication, the first step is initiating the session. At the end of the initiating the session, which should last about 2 to 3 minutes, we will be having develop a collaborative agenda for conversation. It starts with environment, physical needs and mental preparation, and then you need to build the rapport with self-introduction and knowing the client in depth, and then asking an opening question, listening, summarizing and screening. So this we are going to explore this part now in detail. Physical and mental preparation. The physical preparation is obvious. You have to have a quiet, calm, comfortable place where you have a place to sit and there's no noise and there's nothing very busy happening around. So there's a place to talk. But then mental preparation is something that is ignored, and you need to be in a correct mindset. You are not upset, you are not disturbed by your own personal issues, and you are not disturbed by administrative or any other things that is happening. And then it's best that for you to sort of develop an environment where there is no harsh words, no conflicts, no shouting and things like that in a consultation room. Once you have established your environment and your physical and mental preparedness, it's best that you do get into the introductions, knowing each other relevant to the context of the conversation. In some of the conversation, just a matter of that you are a doctor working in such and such a place may be sufficient. But then if you are going to explore deeper into the life, probably you need to give a better introduction as who you are, what you are doing, from where you are. Try to have some links with the patient, try to have some similarities with the patient, so that the patient can introduce themselves, can get into deep parts of their emotional stories. Building rapport is an essential component. Rapport is a trustworthy relationship that goes beyond friendship. And it is essential to have a rapport if you are to share personal experiences and if you want the patient to ask help from you. So therefore, you should take another step beyond building relationship to develop rapport. Asking the opening question is the most important event in the conversation. Once you have built the rapport, take a pause, change your posture and adopt a posture where you are displaying that you are ready to listen, and then ask this opening question. And you must ask, කියන්නකො ඉතින් තියෙන ආපු කාරණය මොකක්ද? So that is the most important part of the consultation. Having asked the opening question, next most important thing is to have effective listening. You should be attuned to the patient's emotions, and then you should be reflective, indicating that you are listening and you are reflecting, and then you should be empathetic. Listening can be at various levels. The worst thing somebody can do is ignoring another person. That's not good. And then some do pretend that they are listening, which is even worse. But then the selective listening is a skill that was taught to medical students in the past with the intention to make them more efficient so that they can gather information correctly, which is a wrong approach. And we need to listen to the entire story of patients. Don't be selective. Now, for example, when a patient talk about a very deep, emotional story, the student, medical student is induced or trained to pick key words. Say, for example, he will pick the chest pain, radiating, sweating and palpitation, and leaving out all the other emotional stories. That is not good. We should have attentive listening. We need to attend to the entire story of the patient. And then we should indicate that we are doing it by reflective listening. And then we should be empathetic and we should get engaged emotionally along with the patient's conversation. And then throughout the conversation, you should indicate that you are listening and you have understood by internal summaries. Internal summary is the way to communicate to the patient that you are listening and you are understanding. That is very important. Until you have an internal summary, a patient may not realize that you are listening. At the beginning of consultation, after your opening question, you listen for about 30 seconds, 1 minute, and then you summarize. That is called internal summary. And then you should ask a screening question. What does that mean? You ask, is there anything else? That's a screening question. Now, there is research evidence to say that if a doctor asks a screening question, the chance of a new, very important symptom or a problem surfacing in that conversation is about 40% of the time. So therefore, don't miss that opportunity and don't don't ignore asking a screening question as well. We are talking about the initiating the session. Now that you ask the opening question, listen effectively, ask screening question, and now you have number of problems recognized. Now you must set an agenda. You must explicitly say that yes, now I understand you have 3 problems, you have 4 problems. That is an agenda. You must understand that, list them, and tell that to the patient so that the patient also agree with you on that agenda, so that you can continue the conversation based on that. Or else patient might tell another topic, still get that also, so that you must have an agenda for the rest of the conversation. Otherwise you might end up in a situation where at the end of the consultation patient will say, I have another problem. So avoid that by setting an agenda. Having come to the end of the initiating the session, now you have an agenda. Now you need to enter the main component, main part of our conversation, that is to gather information. Now you have an agenda, you need to follow the agenda. Take the first topic, second topic, third topic, like that. And then each and every topic is better for you to ask an open question and then proceed to ask close-ended question, which is called open to closed cone. And in the process, moving from one topic to the next topic, use what is called signposting and transition. What does that mean? That means that you will indicate that you are changing the topic and moving to the next topic. And then you must take topic one by one, and then at the end, don't forget to address I's, that is ideas, concerns, emotions and experiences and expectations. So that also is a very important aspect in the conversation. Let me elaborate a little bit more on following the agenda. You take one topic and then ask the open question. So tell me about this joint pain now. And then you may have to ask a more focused question, directive question, different types of question. That is called open to closed cone. At the end you might ask more close-ended question. And then you signpost and indicate that, okay, that is about joint pain, and shall we talk about this skin rash, change in the topic to next topic after indicating. When you explore the story, you may have to use more and more internal summaries and ask more questions, and there will be a lot of other responses from you. You may ask clarifications, you may ask verifications, or you may ask probing questions when you have some area where you need to probe and find out whether that part of the story is accurate. And then some of the places you may have to do a restatement. Now that is what you do is you will be paraphrasing what the patient said and repeating it back to him. And that will be a good way of asking him to reflect about what he is saying. And then echoing is yet another way of doing it. In the similar way, you induce the patient to think about what he said. Say when he is having a very outstanding behavior or unusual behavior, you might echo it, but you will not reject or you will not start criticizing that at that stage. Echoing is the way to induce him to think. There are various types of questions you will be practicing in the real practice session. Opening questions, open-ended question, focus question, I have already mentioned. Close-ended questions are questions where the patient has to give an answer, yes or no, or a couple of words. What are leading questions? Leading questions are things like where you are asking the patient to go in that direction. You are taking liquor, aren't you? So you are leading. You are taking little excess of carbohydrate, aren't you? So they are leading. And then clarifications. Tell me how much do you? Things like that. And verifications. And then there may be compound questions where you have these combinations of both. You can think of variety of open-ended questions. Tell me more about what happened next. How did that make you feel? What happened before this? Things like that. Various types of open-ended questions can result in different types of information. Say if you want to get details about observation, what happened then? If you want to get the meaning of something, what do you mean by that? And then affect, how do you feel? Motive, what do you want? Action, what will you do? And then you must remember that in a situation where you want to get the affect, your feelings, you have to use the tone and the voice in that manner. Say, when you want to learn about the feelings, you are not going to ask the patient, now tell me about your feeling. That tone is not correct. Say, for example, you will have a softer voice and you will say, how do you feel? So that the patient is getting attuned to that, and then give the more emotional answer. Now, this is an important step. Explore the ideas, concerns, emotions, experiences, and expectations. And this is a commonly forgotten area. And in patient-centered approaches, it's always important to explore patients' ideas. Ask, so what do you think? Concerns? What is the worry? Emotions? Tell me, how do you feel? Experiences? How do you manage what is happening at home? Expectations? What can I do for you? What do you expect from me? So make sure that you are attuned with the patient when you try to explore emotions and experiences. Now having going through the initiating the session, gather information, and then you have explored ideas, emotions, and concerns. Now it's time for the physical examination. Here I mean not only the physical examination, clinical, but also examination of the documents and material will come into place here. My advice is, my suggestion is that don't stop communication. You need to continue to communicate during a physical examination. Continue to build relationships. Be empathetic. It's very important to be empathetic during the examination, because if you display harsh behaviors, that's not going to be helpful. Now, after history taking, after knowing about patients' perspectives, your eyes, and examine, now it's time for you to plan collaboratively what next, what to do. For that, you need to explore the background knowledge and understanding of the patient, explore information needs. What do they want to know? And then set an agenda and deliver chunk and check. I will be explaining what it is. And then give opportunities for clarification and summarize your collaborative plan. Collaborative plan should be the way that you do. Always you need to collaborate. You ask the patient, what do they want to do? What is their ideas? How do they want for us to proceed? What they want to do? That is very. The first step in collaborative planning would be to know the background of the patient and then understand their knowledge, their understandability, their information need, and plan topics to share information. Sharing information is one of the most important steps in a consultation. I must say that is the most important step. Now, to share information, it is essential for you to develop an agenda or recognize chunks to deliver that should be based on the patient's expectations. That you can get only after asking the question, tell me what do you want to know? And the patient will definitely ask you the question that you never expected. So therefore, it's vital that you ask the question, what do you want to know? And then listen to the patient and then set an agenda. Just like in the history taking part, you give an agenda, ask, is there anything else? So that there may be 2 or 3 or 4 topics that you have to share information. And then when you share, we call that each chunk of information should be delivered and discussed. And then there should be checking. Did you understand what I said? If it is essential or if it is important, you might ask the patient to repeat what I said again, depending on the situation, depending on the value and the sensitiveness of the information. You may ask the patient to repeat and then move to the next topic with transition and signposting. And that is important for you to follow this process of sharing information in an organized manner to ensure that it is effective. Now we have come to the end. At the end, it is important to have a well-organized closure. Probably we will be summarizing entire process once again. and then develop a contract. You ask your client or the patient, this is what you should do. I will do it. I will do this my part. So my role and your role is defined and declared, and then greeting will end the conversation, and that is the closure. But then never forget the value of allowing room to ask more questions from to the patient. At the onset, when we introduced the Calgary-Cambridge model, you remember there were two longitudinal skills that we have to develop. That is, building relationship should happen right from the beginning to the end. That is why the building relationship happens when we set in the environment, when we greeting and introduce ourselves, when during the process of building rapport, when we ask open questions and listening, that is building relationship. That is very supportive to the patient. And summarizing and screening, again, that build relationship, and that is soothing to the patient. And the collaborative planning and time for question are very valuable and important things that we should do. Finally, as a doctor or anybody who is leading this discussion is providing a structure for that conversation. So taking from one topic to the next topic and introduce another topic, and all that is providing a structure. But then in the process, you must be very sensitive and should not be dominating. You should maintain parallel position and collaborative approaches. So that is very important. That happens when you ask opening question rather than close-ended question. When you are summarizing and screening, when you are setting an agenda, you are providing a structure. When you are signposting and doing transitions, you are providing a structure. When you are developing internal summaries, that is a structure. And then at the end, you provide a contract and closure. That again is a way of providing a structure. So that is the skill that we have to develop. So that come to the end of that lecture. We discuss about skills in communication, and there will be another series of questions for you to respond before you move on to the next lecture, and I hope you enjoy this lecture. Thank you.